Good evening, everyone. I think people will just be trickling in. Good evening and Happy New Year to everyone. I hope you had a good holiday. And welcome back or welcome to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. If you've been here before, my name is Leslie Rattan, and I'm very pleased to be moderating our webinar series, which has been developed for people that are struggling with prolonged symptoms after concussion, their caregivers and healthcare providers. The sessions, we took a break over the holidays, but the sessions will be once again recurring every other week on Tuesday evening at 6 p.m. And just so you know, the sessions are recorded and posted on the Canadian Concussion Center website. So if you miss one, you're able to go back and watch it there. The format, if you're not familiar, starts with a half an hour or so talk by an expert speaker in different areas of concussion. And then that's followed by a Q&A, question and answer segment where you can get your questions answered. So just so that you know, if you look at the bottom of your screen, you'll notice that there is a Q&A. So that's where you will click if you want to pose a question to our speaker tonight. If you're having any technical difficulties, go into the chat, hit the chat button, and you can enter questions there, and Christian can help you out. You'll also see that he has posted a PDF of tonight's presentation if you're looking for it, so you can find it there. Now, just before I proceed any further, we're just going to run a very short poll. It's helpful for us to know who we have in the audience. So if you can just quickly respond to that, and then we can move forward. Thank you very much. So for this evening's session, I'm really pleased to introduce Dr. Eric Massicotte, who we have had with us once before. He's going to be presenting on whiplash, and his title, as you can see, is What a Pain in the Neck. Dr. Massicotte is a graduate of the University of Ottawa School of Medicine in 1995. He entered the neurosurgical training program at the University of Manitoba immediately after, and transitioned to the University of Toronto for his senior years. During his time in Manitoba, Dr. Massicotte completed a Master in Science with the Department of Surgery. His research focused on white matter changes in the rat model under the supervision of Dr. Marc Del Biggio. He became a fellow of the Royal College of Physicians and Surgeons of Canada in 2001. In order to further his interest in spine, he undertook a fellowship at the Toronto Western Hospital under the direction of Dr. Failings. The Complex Spine Fellowship also provided him time with Dr. Lewis and Dr. Rampersault. He is now Associate Professor in the Department of Surgery and member of the Division of Neurosurgery at the Toronto Western Hospital. His clinical practice focuses on spine with research interests in outcome measures and medical education. Dr. Massicotte has been appointed medical director for 2 programs at Altum Health, back and neck and concussion. The latter was an innovation started in collaboration with Dr. Charles Tatter. And with that, I'm going to turn it over to Dr. Massicotte.
Thank you, Leslie, and thank you to the organizing committee for inviting me again to speak on this topic. So the presentation that I've put together tonight is really focusing on neck pain and not just whiplash. So those of you who are hoping a whole 30 minutes of whiplash talk, you'll be disappointed. So let me just move forward here with the slides. So I think a lot of this stuff has already been covered. Really, I don't have any sort of disclosures or conflict of interest with anything that I'm going to be presenting tonight. What I want to do is I want to review the topic of neck pain and really sort of emphasize sort of how different specialists look at neck pain and kind of approach it. And this will help, particularly for members of the lay public. Sorry, I'm also on call for spine, so if my page goes off, I might get distracted here, so I apologize for that. The the approach that one has to neck pain will vary depending on where their training is from and how they're approaching it. And this is kind of important to understand, especially from a layman's point of view, because sometimes they don't appreciate that, if you're a surgeon, you look at it from a surgical perspective. If you're sports medicine or a physiatrist, you may approach it in a slightly different way. But as a person suffering with neck pain, you just want the pain to be gone. So the second point here in terms of objective is really to demonstrate or illustrate some of the collaboration between different professional management when it comes to the topic of neck pain. Really, some of the topics here is to talk about concussion and cervical strain, talk about radiculopathy and myelopathy, because that certainly is something that as a surgeon, we're really, keen on identifying early, and it can have a number of co-founders when we're dealing with individuals suffering with concussion. And then obviously, touching on management with regards to surgical interventions, and then really kind of an important message about focusing on muscles and why is core strengthening and posture so important. So to this audience, obviously, the concussion definition is important, but really it's kind of relevant here to remind ourselves that we're talking about a temporary alteration of mental function due to trauma. And the trauma doesn't have to be directly to the head, and it can be sort of a whiplash effect that can be felt, below the brain. And so that's why there's a great deal of overlap in the patients that we see with concussions and whiplash injuries or cervical strains, etc. And so this is why I think, it's relevant in this context to talk about these neck pain. When we're building differentials, and more we're seeing, people kind of look at headaches and different pains, they sort of go to the internet and they punch in all these symptoms and they try to find out what the sources are. And you have a constellation of different things. And, some of these entities or diagnoses can be quite scary and quite distracting, and sometimes lead you down, sort of the wrong path. Obviously, there's different, sort of way of organizing your thoughts, particularly if you're looking at an approach to, say, headaches, for example. You have certain steps that you want to go through, certain things that you want to identify. And this is, sort of a nice algorithm that kind of illustrates the logical and methodology behind sort of how do you approach someone with a headache, and how do you kind of dive down. But what you have to remember is that, headaches and neck pain, because of the proximity in the anatomy, etc., and some of the overlap with some of the tissues and specifically the pathophysiologies, sometimes can be a little bit confusing. So someone can come in complaining, saying they have a headache, but when you start taking more of a history, you find out that they actually have cervical strain injury. So this is important to keep in mind and make sure that the communication when you take a history is as accurate as possible. There's a number of trigger points, and this sort of diagram illustrates nicely sort of the different areas and how this sort of combines together. So if we're talking about the source of neck pain, how do we sort of structure or organize our thoughts over this? Well, you could sort of come back and say, well, what are the anatomical sort of breakdown for this? Or, should we look at a pathological process, or should we look at biomechanical? Well, obviously the answer is not just one thing, but it's a combination of all of these. And you can sort of get a sense here that when you start looking at it this way, it's very complex, and there's a lot of different components that have to be taken into consideration. So this is not just a straightforward sort of little checkbox or little, sort of buckets that you go through and easily put in, sort of where somebody is supposed to sit. If we look and overlap the neural circuitry, and this is just a couple of examples of how the different pathways are, sort of connected, and looking at these things, this is fairly complex. And although we have, gained a great deal of understanding when it comes to the neural circuitry, the emphasis here is to really appreciate that it's not just as straightforward as, sort of a light switch and a light bulb, and there's just a connection. And as long as you understand where all the connections are, you can figure out what's broken. There's a great deal of, sort of overlap with all of this, and much more complicated. Just one point to illustrate off of this diagram is if you look in the bottom left, you have spindle receptors here looking at muscle fibers, really trying to emphasize the point that when you have these receptors that are activated, this can also present some, constellation of symptoms associated with this. Even if we try to simplify this and look at, simple things like head movement, vibration, rotation, vestibular signals coming in from the inner ear, etc., you can see that the interplay between all of these can be quite complicated, and each one will have an impact on another. So this is why sometimes patients come in and they don't have just a concussion with a few symptoms like headaches and dizziness. They can also have cervical strain. They can have injuries that can create a number of other symptoms that can be quite challenging to manage and to deal with. I like showing this picture, and I show this to medical students as well as to a number of other audiences, but really this illustrates the point that the anatomical resolution that we get with MRIs is very, very high. We can look down at the actual specific different tissues that are involved, and we can also appreciate or pick up very subtle changes of, signal changes within the different tissues, if the tissues are a little bit more edematous or inflamed or irritated, etc. And so this allows us to gain a great deal of insight and visibility on all these things. How do we take that into the context of looking after patients that present with different sort of presentations of neck pain? So we're lumping all the neck pains together. Well, as a surgeon, really what I want to tease out with all of this group of individuals is there a component of these patients that are presenting that actually have a radiculopathy? And by radiculopathy here, we're talking about compression of a nerve root in the neck, resulting in a radicular type pattern of pain. And the diagram by Netter up in the top middle there, you can see an axial cut where you can see the nerve is being pinched by a herniated disc and an osteophyte. Myelopathy is the next sort of category of patients that we're really quite concerned about. And these are individuals where the MR pictures are more sort of representative of that. And the autopsy specimen shown in the middle with the spinal cord being compressed really kind of illustrates this as well. This is the patient population that we're really concerned about, because that patient population has compression of their spinal cord. Very simplistically put, the spinal cord is the connection between the brain and the rest of your body. So whenever you want to move something, or whether you feel some sensation, it goes to your brain. All of these signals have to connect and go through your spinal cord. So for those of you who live in Toronto, it's like Highway 401 in the summer. All the signals go through there to exit the city. And so when you close a couple of lanes, you can automatically appreciate a great deal of backlog in traffic. And it's a little bit irritating when you're stuck in traffic, but when you're talking about the spinal cord of somebody, this can result in profound sort of deficits, both sensory and motor, and have a major impact on quality of life. So the individuals that I try to tease out when they present with neck pain are the ones that have a radiculopathy or have a myelopathy, or combinations of those two things. But of course, the vast majority of individuals that present only have axial neck pain for other reasons, and not necessarily compression of the neural elements. So how do we tease out, who do we need to worry about? Well, you've heard of red flags, and these are certain things that on history and on physical examination we look for, because these tend to tell us that maybe there's something a little bit more ominous that's happening underneath all of that, and we need to make sure that we don't miss these individuals. And this is a nice list that is fairly comprehensive of red flags that we need to keep in mind when people present with symptoms. Here's a little clinical vignette of an individual that presents, and these are the typical patients that I see in my office. A 42-year-old gentleman presents with a 10-month history of a C7 radiculopathy. His pattern of pain is down the arm, not so much pain in the neck, but mostly pain down his right arm. And his MRI confirms that he's got a herniated disc and it's pinching the nerve, the C7 nerve in this case. And this is the type of individual that actually does really well with surgery. And the type of surgery is called an anterior cervical discectomy. And this is what the picture in the middle there is what I see during surgery, which is a plate that's been put on with a graft that's put in. The X-ray that's over on the right, you can see the side view of the neck with the allograft in place, etc. And the idea behind this is that if you take the pressure off the nerve is a little bit happier and tends to do very well. The surgical outcomes from this are very, very good. And I put this slide up here, and some of you are probably wondering, why is he putting up a slide of a golf course? Well, the reason I put this out is because when we do studies and we do sort of patient outcome measures, etc., there's a number of different measures that we can use. Patient-centered questionnaires or sort of disease-specific questionnaires, etc. But really what's relevant is what it boils down to is the quality of life. And in this case, for this individual, this 42-year-old gentleman was playing golf. And so he was able to get back to playing golf, and this was a huge sort of boost in his quality of life. And so he was very grateful. And that's why you've got a picture of a golf course. 10 bonus points for those of you who can identify where this golf course is. It's not a public golf course, it's a private, so it's very challenging. So here's an example of another patient, a little older individual who presents with myelopathy. The presentation there really involves someone with motor weakness, sensory abnormalities. Sometimes they can present with gait instability. And that can throw primary care physicians off a little bit because they're more thinking about something in the lumbar spine, not necessarily in the cervical spine. But in fact, the gait abnormality is because the long tract fibers in the spinal cord are being crushed and affected, which results in their inability to stand properly. So these individuals require a bigger operation. And the kind of operation that is typically done from the back because of the number of levels that are involved, where we remove some of the bone, and you can see a picture intraoperatively halfway through the operation there, where we've done a laminectomy. We've removed the bone off the back to create more space inside the spinal canal. The X-ray is an intraoperative X-ray, and you can see that the other part of this operation is not just the decompression, but also the stabilization of the bones. So an instrumented fusion, and we put in screws at each of the levels and connect them up to rods. Patients typically do very well with this, and in about 90 to 95% of cases, we're able to stop any further progression of neurological deficits. This is a big deal because obviously progression of neurological deficits can lead to quite devastating impact on overall quality of life. Some patients, somewhere in the neighborhood of about 60 to 65%, will see some improvement as well. Improvement in the amount of numbness, the dexterity in their fingers, steadiness on their walking, and overall ability to control their sphincter function. So again, very important to identify patients that have this and identify them early as opposed to too late and intervene with surgical means. Now, what about the majority of patients that present with neck pain? What are the conservative treatments for neck pain? Well, the best evidence that we have, which would suggest that educational intervention, which involves sort of an active process of engaging the muscles and really kind of getting the patients to understand that what we're dealing with here is mostly muscle tissue, and that's what needs to be reinforced, and posture plays a big role. This illustration, an anatomical illustration, really sort of makes the point that if you take a cross section in your neck, the bulk of the tissue is actually muscle. So if the muscles are not well balanced, in other words, the muscles in the front versus the back, or you have bad posture, in other words, you're putting more stress on one side versus the other, This can lead to accelerated degeneration and wear and tear, and can lead to muscle spasm and muscle fatigue, which can cause even more pain. So part of the strategy in a lot of these conservative modalities of treatment is to focus on getting muscles that are nice and healthy and strong and provide more support. So there's less stress being shifted over to the bones and ligaments and sort of bony structures of the spine, which can lead to more wear and tear and degeneration. One of the core principles of modalities of treatment is really to think of it in a very holistic way. And just like we do for concussion treatment at our center, we break down all the different symptoms into different spheres, and obviously all the spheres have a great deal of overlap, but we try to address as many of these. And it's the same thing with neck pain. You want to make sure that you address some of the educational and make sure the patients understand what we're trying to accomplish, and really kind of get at the basis of it. Part of the challenge is that, for a lot of these treatments, it means a change in lifestyle and really sort of focusing on an active participation. So for some patients, this is a little bit difficult to be compliant with, because they'd rather have, just take a pill for a couple of weeks and have their pain just magically disappear. But really, the strategy is more about a sort of active process where they're engaged. And this is best accomplished when patients have a true understanding of what the underlying pathology is. Some patients say, well, if ultimately the end result is to have surgery, why don't I just, skip to the head of the line and just get the surgery done and get it over with? But in fact, even some of my surgical patients, I will recommend sometimes a course of conservative modalities of treatment beforehand, because if they can avoid surgery altogether, that's better for them. And in some cases, even if they do end up getting surgery, the better condition your muscles are in before the surgery, the easier it is to tolerate it. So it's important to understand that doing core strengthening and exercise and posture is a good thing no matter what. And it's not a waste of time. It's not just, sort of spinning your wheels or wasting everybody's time. So hopefully with this, I've covered, sort of enough ground to sort of cover the topic of neck pain and emphasize that, neck pain has multiple sources. It's very complicated, but there should be sort of an approach. And for the vast majority of conservative modalities of treatment is really a focus on muscle. Therefore, core strengthening, active participation and engagement, and posture are really kind of key. At this point, I'll stop and open it up for any questions.
Great. Thank you so much, Dr. Massicotte. That was excellent. I'm going to go just to remind you, if you have any questions, please enter those into the Q&A. So our first question, I have had multiple concussions and whiplash a few times. I also have scoliosis. It is causing a pinched nerve from C4 to T2. I get severe sub-occipital headache. Is there anything that can be done to prevent the nerve impingement, as I can't always get to the chiropractor when it happens?
So in my talk, I had a slide on chiropractor and chiropractic manipulations. As a general rule, I don't really endorse chiropractic manipulations. And again, here we have to be careful. Chiropractors are individuals who, have different modalities of treatment, but the one modality of treatment that I really have trouble in understanding how it really kind of benefits someone, particularly someone who has, a spinal deformity and specifically impinged nerves. I don't understand how chiropractic manipulations would have any benefit. So having said that, I'll stop there. I think that, the scoliosis is, a condition, a degenerative condition. Some people are born with it and it can evolve over time. And, that condition can be somewhat contained to some degree with, posture training and core strengthening, but that also has a limit to how much you can do. And there's some individuals who really end up in a state where the only alternative is to consider surgery in order to, decompress some of those neural elements. So it's a very complex question that you're asking me, and there's not a simple answer. I think that, there's lots of different options that you have to consider, which can span everything from, conservative modalities of treatment with core strengthening and posture training. And obviously, if that fails, then you need to sort of elevate it to the next level, which would mean maybe more, sort of aggressive or invasive interventions such as surgery. And in order for, to understand all the different options, it's important that you be seen by someone who has a good grasp of all the different options available to you, and not just a very narrow spectrum of what is available. So I would recommend that you be seen by someone who, kind of understands your issue and understands the complexity and is able to sort of walk you through all the different options. So I think hopefully that's helpful for you, but it's a very challenging situation because it's not, you have the concussion on top of the scoliosis, and it sounds like you have some pinched elements or neural elements in all of this, which can obviously exacerbate your symptoms and, contribute to many of your symptoms. So it's not quite as straightforward as, just a dislocated rib that the chiropractor can just pop back into place. I don't think that's an oversimplification, and it may not lead to a very positive outcome for you.
Okay, thanks so much. Our next one says, great presentation. Where does nerve ablation come in?
Yeah, so a lot of the pain specialists, or let me rephrase that. A number of pain specialists use that as an option, and there's different ways of destroying the nerves. You can use radio frequency, you can use sort of glycerol injections, etc. But part of the idea is that if you imagine a nerve being pinched, you can just sort of burn it or destroy it, and hopefully take away some of the pain sort of stimuli that it receives. Part of the problem is that for some of these nerves, this doesn't really work quite so well. And so it's not always a solution. And also you have to think about what's causing this pain, to the nerve in the first place, because, just like trying to address a headache, you're trying to get at the cause of the headache, not just the symptoms or the pain. And so it's important to understand where that's coming from. For some individuals, when they have a number of different sort of pain presentations, nerve ablation is one of the options that's tried out. And, there's mixed results with that.
Great, thank you. Shelley is asking, what might cause chronic headache after whiplash or TBI, and what can be done about it?
So I think, one of the slides that I showed you, which was, sort of a shopping list of all the different tissues and the different pathologies, and then overlapping that with the neural circuitry, this is where, some of these things can be out of whack, and we can understand each of the individual circuitry. But one of the challenges that we still face is when a lot of these circuitries are overlaid one on top of each other and how they influence one another. And so you can end up having these trigger loops that cause some of these pain syndromes that continue, for months and sometimes years after the initial injury. And so, we at the end of the day, we don't really know why some individuals fall into that category where they are, perpetually stuck in this cycle of having pain and having particular, neck position triggering, devastating neck pain and, contributing to their headaches, etc., and some of their concussion symptoms. So we don't really have a good grasp on what are some of the triggers. Sometimes we can identify some of the triggers, and then there's different strategies for those. So if we're talking about muscle spasms, for example, some individuals have tried Botox injections so paralyzing the muscles, just to try to, bring down some of the pain that they're experiencing and sort of bring it into a little bit more of a manageable kind of scenario. Other strategies may involve pharmaceutical interventions, such as neuroleptic medications, so medications that kind of quiet down. And some of these fall into the category of being sort of anti-seizure medication. They, as a general rule, they just kind of bring down the nervous activity of some of these nerves in order to make it a little bit more tolerable for patients with these symptoms. So different management strategies will depend on, how severe it is and what we think some of these triggers that are playing, the major predominant role.
Great, thanks so much. And Shelley, I would just add as well that we had our last presentation in December, which is now on video on the website, was on specifically on headache. We had Dr. Marie Slager with us, so you might find some additional tips in there. Next question. If someone developed bone spurs after having a cervical fusion, do you remove them surgically?
So one of the things to realize is that we develop bone spurs throughout the course of our life. So I probably have a bunch of bone spurs right now, so do many people on this call. And so if we start chasing bone spurs, we're going to have quite a lot of work on our hands. So the only time I go chasing bone spurs is when these bone spurs are actually causing trouble and they're impinging or causing irritation of specific nerves, or in some cases, the spinal cord. So these bone spurs can happen following a fusion or following surgery. Most of the time they happen without. But the role for removing the bone spurs or decompressing is really reserved for individuals who are symptomatic and, all else has failed, then you go in and do surgery.
Okay, great. Thank you. The next question is, what type of pillow do you recommend for neck pain? And I'd actually add, is there a sleeping position that's best for our necks?
So I get this question in the context of individuals with concussion, with cervical strain. And I also get this question from my patients following surgery after I've, fused and taken away some of the mobility in their neck. The answer is there's no one specific pillow. Everybody's got, a different position that they're most comfortable in. Some people are more comfortable in their back, other people on their side, other people on their front. So, again, it really depends. And obviously the type of support or pillow is going to vary on your position. The other thing that we have to remember is that, you may start off on your back, but then throughout the course of the night, you're moving around. If you have a partner in the bed too, then that person's, probably nudging you when you start snoring or something. And so there's a lot of dynamic sort of activity that goes on there. So it's not, so I can't just sort of sit here and, and with a straight face say, you need a Massicotte SPF 2000 pillow, and here's the website, I'll sell you those pillows. And you have to sleep on your left side with the right leg support. No, there's no such answer. You have to figure it out, on your own and sort of go through a trial and error. What I will say is that I often see a lot of patients with too many pillows, and so they force their neck into a flex position. And what that does is that if you look at the anatomy of your neck, a lot of the muscles are in the back because they hold your head up. So if you force your head forward, you keep those muscles under a great deal of tension, and then the muscles will go into spasm more easily, and that can cause a great deal of pain. So all too often when people come in, they say, oh, I'm having trouble with these pillow and, my head, is really kind of pushed forward and my neck goes into spasm, etc. What they're probably doing is they're putting too much behind their head and forcing themselves into flexion. So when you go to bed tonight, just be mindful of your position and figure out like, okay, how exactly is my head positioned? Am I translated too far forward? Am I flexed? Am I too far back? Most of the time, people are more flexed than too extended, but you have to kind of look at all these things. And for individuals who've had a whiplash injury or have had a cervical strain, a little neck position that's a little bit out of whack may be okay for 5-10 minutes, but after a couple of hours, that can trigger neck spasm, and that can cause a great deal of pain and discomfort.
Okay, great. Question, is a muscle relaxant effective for neck pain relief?
So we talked about this before with regards to different pharmaceutical strategies, and muscle relaxant is one of them. And again, I don't want people to think of, pharmaceutical approaches as a magic bullet, or, just one of those things, like one thing takes care of everything. If the majority of your neck pain is coming from neck spasm, ultimately what's going to help you long-term is, sort of developing those muscles, core strengthening, and good posture. Now, if you're not able to engage in exercise and really recruit those muscles and get them going, etc., then maybe using a muscle relaxant in the acute phase to get the muscles to relax a little bit in order for you to do those exercises and get going is a good strategy. But if your strategy is just to take muscle relaxants and not do anything else, then that's not a good overall strategy. The long-term solution is having good muscles. Even individuals, we know that individuals who smoke, will have issues with the vasculature. It'll affect the small vessels, and it'll cause advanced degeneration in your neck. But if you have good muscles in your neck and you're able to bring good blood flow, you can regulate some of the inflammatory responses, and you can also provide more support. So there's less stress being translated to the bones and ligaments. And that's ultimately a good strategy.
Okay, great. How can you tell if you have a pinched nerve?
So so that can be a little bit tricky to diagnose. Usually the pattern of a radiculopathy, a pinched nerve in your neck, for example, or it can be in your lumbar spine, so down your leg, is that the pattern of pain will be predominantly in the arm as opposed to the neck. Now, the majority of the patients that we see, or that I see, will have a mechanical compression, but you can also have muscle spasms irritating the nerves as they travel through that muscle fiber. So sometimes a radicular pattern may present itself, and there's no pinched nerve. There's an irritated nerve from inflammation and muscle spasm that has created it. So what we'll do is we'll image the patient with an MRI of their spine and look for the, where the nerves are going and whether there's any impingement. So this is sometimes causing a little bit of confusion, because patients will come to me and they say, well, my pain is going down into my arm, so it's got to be a pinched nerve. And I say, well, no, I've looked at your MRI and I don't see a pinched nerve. So there's nothing that I can do surgery on. But they say, well, yeah, but my pain is still there. So where is it coming from? And this is when, you have to think about, okay, well, is the nerve being irritated at another station down, down the road? And is it coming from maybe a muscle or a ligament that's sort of encroaching on the nerve and causing inflammation?
Great, thank you. Next one is a bit of a long one. So my son suffered from a concussion in March of 2021. He's gone to vestibular and vision therapy for 4 months right after the incident. He was then sent to physical therapy due to continuous neck and right shoulder pain. The MDs now want him to get Botox, which he is inhibited to, and again have the vestibular therapy. Sorry, I'm not sure I'm clear on that. However, he feels the vestibular therapy will not serve to be supportive because once it ended previously, he didn't feel any further relief. Would you have any suggestions for further therapy? How could we identify other causes? So I guess it's coming back to this neck and right shoulder pain.
Yeah. So for the vestibular stuff, I mean, I think I'm sure you'll have a speaker on this from ENT, they're really the experts when it comes to vestibular sort of overstimulation, and particularly understanding who's a good candidate for vestibular therapy, etc. With regards to, sort of the shoulder pain and associated neck pain, that one, is a little bit more challenging. And certainly if engaging the muscles and doing the core strengthening is difficult because of, vestibular issues, because every time you do exercise, you're over activating, sort of this dizziness, the inner ear, etc. Like, again, all of these things are balancing act, right? So you can't just sort of rely on just one thing. But this sounds like a very sort of challenging case, and most likely the team that's looking after your son will need to sort of recruit experts from ENT to sort of think about what can be done from a vestibular point of view, and maybe some physiatrists to look at, is there a role for, how to recruit the muscles in your neck, and how to sort of best optimize their conditioning. Clearly, when someone has gone through, sort of a devastating injury like a concussion and has not been able to engage the muscle, there's a great deal of deconditioning that can happen. And if we're talking about, sort of March of 21, we're approaching on 2 years now. So you can sort of, appreciate how someone's muscle will go a process of degeneration and deconditioning, which can then make it even harder when you start to engage those muscles. So you have to kind of break a cycle to recreate and retrain those muscles. And that can be quite challenging and a very lengthy process.
Okay, thank you. I have an mTBI, mild traumatic brain injury, and whiplash. I've been using lidocaine injections for pain and headache for the past 3 years. They're wanting to know, what do you think about lidocaine injections in the long run?
Yeah. So, if it helps you, then obviously, you got to carry on with that. Certainly for the neck pain, the long-term solution, like I've said before, is really to think about how do you condition your muscles to be in the optimal sort of state. Optimal state meaning, nice toned muscles, balanced muscles, particularly, sort of muscles in front of your spine versus the back of your spine, left side and right side. Because when you have an asymmetry, probably the best example is, your bicep and your tricep. When the biceps are overdeveloped and the triceps are too weak, this puts, sort of extra stress on some of the joints, particularly the elbow, and that can result in a great deal of pain. So when we're talking about muscles that are in balance and well conditioned and toned, this is what we mean. And sometimes this can be quite challenging, particularly if you've been suffering for 3 years. So chances are you haven't been recruiting those muscles the way you should. And so getting that cycle, to undo that cycle and really get on to a way of toning those muscles properly, having them balanced, and then maintaining a certain posture that allows for the muscles to sort of exist in a state that is comfortable for them. That's ultimately what you want to get at, because doing injections is kind of a temporary relief. Certainly from a muscle point of view, it kind of numbs the receptors a little bit and it lasts for whatever length of time, but it's not ultimately something that, you can function with. And for some individuals, this toning process and core strengthening and posture allows them just enough, sort of relief. And what they notice is that their tolerance for activity improves. So without that tone, they're not able to, say, go for a walk around the block, or, go to the grocery store and carry a grocery bag back home. That act of carrying the grocery bag throws off their balance, and it throws off the stress on their neck, and they can't tolerate it. So, this is where you can see the impact on your quality of life when you don't have that tone and that, strengthening process.
Great, thank you. I get cramping, spasming sensations in the occipital area and what I would describe as below my brain, in the center of my head, above the roof of my mouth. Can that stem from the neck muscles, Also a burning sensation on my scalp above it, with an incredible urge to tighten or pull my hair. Can you say anything about this?
So there is an occipital nerve which comes out in the back of the neck, and it kind of comes over, sort of like, a web-like distribution, and there's one on each side. So typically there's one for the right and one for the left. And this occipital nerve can often be sort of impinged as it exits the spinal canal. So it can be impinged by sort of bony spurs or those sort of things, but it can also, because it goes through a number of different muscle fibers, it can also be irritated at that level. So if your neck muscles go into spasm, the occipital nerve can be, sort of pinched off or irritated as it goes through. And then the pattern of distribution will be kind of coming up, and it sounds like what you're describing, because it comes up to the crown of the head, and it can feel like a hypersensitivity of the scalp or burning sensation, or very discomfortable, very uncomfortable sensation. So the answer is yes. The strategy here, for some individuals, because it takes a long time to condition the muscles, is, sometimes going after some of these muscle fibers in the back and trying to either do, sort of Botox injections to freeze them, or to try to do a muscle relaxants and that sort of thing.
Okay, great. Thank you. Just to let everyone know as well, Hazel, an occupational therapist who's attending, had just made a recommendation about a pillow that she said that she's found that she's had great success with. So she posted that in the chat just for anyone who's interested. We have another question. When a therapist works on my neck, my tinnitus starts up. Is there a reason for this?
So again, you have to remember that if your neck muscles are deconditioned, the muscles are, sort of atrophied, and they're not used to working, and all of a sudden you're sort of going, okay, let's kick it back into gear. Well, those muscles are going to be a little bit irritated and inflamed. And so you have to find that balance between engaging the muscles, getting them stronger, and not overdoing it and not getting it, to the point where the muscles are so pissed off, they're just hurting too much. So the strategy that I usually recommend, and this is a challenge because, when you go to see your physiotherapist, you go see them, maybe twice or three times, or maybe 4 or 5 times a week, but you go for a session. And so you have that time. And so you say, okay, I want to get maximum impact for that time. But really what you want to do is you want to learn how to do some of the exercises, and then you want to do them back at home. The people who see the most success are the ones who take the bundle of exercise and say, okay, let's break this off into small little bite sizes now. And they do 5-10 minutes in the morning, give their muscles a couple of hours to relax, and then they come back and they do another couple of 5-10 minutes mid-morning, and then lunchtime, mid-afternoon, evening time. And essentially what you're doing is you're engaging the muscles a little bit, but not overdoing it. And as you sort of engage and chip away at it, then the muscles get more toned, they've developed the endurance, they develop the strength. And all of this works in nicely because then your posture starts to be a little bit better, because now you're balancing things out and you see some benefit. Now, you can see how this would have quite the challenge with someone who's having lots of neck pain and who wants a rapid result. It's like training for a marathon. You don't just get up one day, roll out of bed and go, marathon time. No, you got to train for it. You got to build up to it. And the strategy here is a little bit at a time, inching your way towards it. So, for some of my patients, I tell them, say, listen, 5 minutes, not more than that. You do 5 minutes at a time, give your muscles some rest, and then come back to it later. Yeah, but doc, I want to do like 5-hour workout. Yeah. Great. You're going to do a 2-hour monster workout on Monday, and then you're not going to do anything until Thursday or Friday because you're in so much pain. That's not how you're going to build tone. That's not how you're going to build that endurance, and really see some of the benefits.
Mm-hmm. Great. Thank you. Nadine is asking another positioning question. What is the optimal position when using my mobile phone while sitting?
So I think we're going to have a whole generation, because I looked over at my son and he's on his device now again. We're going to have a whole generation of individuals who are used to this kind of position. I think the right position, your body gives you cues, right? So if you're in one position for too long, you get pain, you get, a little muscle twinge, etc. The key is really to listen to some of those cues that your body's giving you and to say, okay, wait a minute, no, my head is too far back. This is uncomfortable. This is comfortable. Everybody's got sort of that resting point that they need to find. And, unfortunately, when you're looking at a mobile device, you're kind of forward flexed, and, you're better off sort of up front. That's why you've seen a number of workstations, for example, that have those standing desks. You have the sitting down and I've been sitting at this desk. I love this desk in my house, but it's at the wrong height. And I'd love for it to be sort of on these stilts so that I can bring them up and I can stand up for a little while and change position and move around. That's ultimately kind of what you have to do, is you have to find what your right balance is and be able to change positions regularly, not just sit in one, fixed position for an extended period of time.
Okay. Yeah. Okay. Thanks so much. We have one last comment. I think this is more of a comment just with regard to chiropractors. And I know sometimes this can be a
Delicate issue.
A bit of a delicate issue, but this individual is indicating that it sounds like they have had success with their chiropractor and that their chiropractor doesn't always, she's saying, doesn't always endorse chiropractic manipulation, but does something called active release and acupuncture. And I guess that has been.
Yeah, I think that's an important point. And I really want to emphasize this. Chiropractors have a number of different modalities that they can use to treat individuals. What I don't understand is chiropractic manipulations. It's kind of like saying, this joint hurts. So what I'm going to do to it is I'm going to bend it back and forth a bunch of times, and that's going to take away the pain. To me, that doesn't make any sense. There's nothing that I learned in medical school that tells me that if, my neck is hurting, I'm just going to move the joints around and, trying to sort of make them crack, etc. And that's going to take the pain away. But there's a number of chiropractors who sort of understand their role and really see and do some education and, teach about principles of core strengthening and really teach about balance and, finding the right alignment for people and really educate them on these points. And they do a great job because they spend the time with the patients to really go through some of these things, and people see benefit from that. And I think this is where we have to be careful when we say chiropractors. No, it's not chiropractors. It's chiropractic manipulations. It's, cracking a joint, to try to make it hurt less. That's not necessarily the right strategy, but just to think about the overall sort of alignment. And the spine is a complex series of joints with a lot of receptors involved. And, to apply a very simplistic approach sometimes doesn't do it justice.
Great. Okay. Thanks so much. If you don't have regular neck pain, can this still be the cause of headaches?
So I've seen a few individuals who really, when you ask them, they don't have any neck pain. They just complain of headaches. But really what they're talking about is a tension headache, which is coming from the muscles and some of the tissues that go from the back of the head to the front. And so, when you sort of dive a little bit more into questioning them and really trying to understand what's at the source of this pain, the overlap between headaches and neck pain is very, very close and sometimes difficult to tease out. So is it possible for someone to have, what they're describing as headaches really being caused by some of the muscle tension that's at the base of the base of the head? The answer is yeah, it can happen.
Okay, great. We have one final question, a good one to finish on. How can I book an appointment with you?
That's an easy question. And I thank you for the question. The challenge that I and many other, spine specialists face in this province is that there is really a lot of individuals who are asking for consultations, but because of access, because of really severe resource deficiencies, I've had to work on, working with a team of individuals. And so the referrals that are sent to me, I would say about 80% of them get redirected to another member of my team. And those individuals kind of go through. So I have a physiatrist, I have an orthopedic surgeon that works with me, and we kind of filter through all of the consults. And we go through a series of different conservative modalities of treatment, etc. And then if you do need surgery, then you end up sort of meeting me. But if other things can address your issues, such as sort of core strengthening, etc., then you may get redirected to one of the other team members on my team. So I'm happy to take any consults, and the contact information is in the PDF that was circulated. But don't be surprised if the consult request from your family doctor gets redirected to another member of my team. These are people that I work with and that I trust. They've been working together for many years, and it's proven to be, fairly successful at trying to see as many people as possible in a timely fashion.
Great, thank you. We just had another question come in, another chiropractic one. They're asking, have you heard of something, I think chiropractic NUCCA, N-U-C-C-A? A lot of concussion patients talk about it helping them. I'm not sure. I haven't heard of it myself.
No, I haven't heard of it myself, so I can't really comment.
Okay. And someone is asking, where is the PDF? It is in the chat. I know a few people have asked that. Christian has posted a few times. So Christian, maybe if you can just post it one more time. He has posted the PDF for tonight. He just posted it again. He had also posted the link to our website where you can find all of the recorded videos. So I think we're almost at time. And I think we've gotten through pretty much all of the questions, so which is great. So I just want to thank you, Dr. Massicotte, for taking your time out of your extremely busy schedule to talk to us tonight. And just to remind you, those of you, there will be a very quick survey coming your way. And we'd really appreciate if you could just take a minute or two to complete that and just provide any feedback, suggestions you might have for us. And as a reminder, our next session will be occurring in 2 weeks on January the 24th, Tuesday night at 6 p.m. We're going to have Dr. Apame Tarasi with us. She's a neurologist, and she's going to be moderating a patient panel. So these are all individuals that have suffered from concussions and will be available to talk about their recovery and answer any questions that you might have. So thanks again. Thanks all of you for attending, and I hope everyone has a great night. Take care.
Good night, everyone.
Night.